to be chatting about fertility, and we are excited to be back with you. So we've got another interesting show lined up. We are going to be talking about pre-treatment for patients with endo before they go into their IVF cycle. It's an article that is so early in its press, they haven't even set up the actual pre-proof kind of part of the article, but I managed to download it today, and so we're going to share that with you and go over it, and then as usual we'll answer all your questions. So grab something to eat or drink, and we'll be with you shortly once you've all had a chance to join. And in the meantime, I hope you've all been well. We certainly had some rough weather today, and I was driving back from Toronto, which was insane on the highways. But special thanks to my wife who lent me her car, and I survived the drive. And here we are. So back safe and sound and excited about doing the show. Hopefully you guys have all been well. And for those of you that are local, obviously we've still been struggling with relatively high rates of COVID, so it's not over yet. And for those of you that hopefully saw the post, we had our first embryo transfer results back, and we are happily pregnant with twins. So I want to send out a huge thank you to my entire team who got on board and put that together, and everyone that was involved. Special thanks to all of you for making that very amazing event come true and become a reality, both for the couple who are absolutely flabbergasted, and for myself and for everybody involved. So thank you to all of you for everything you've done. Amazing work to bring that momentous occasion together, and I am really infinitely proud of everyone involved. So thank you to all of you. Thank you for being part of it. So I can see people asking questions already. So I am happy to have all of those come on board. Yeah, we've already started doing our embryo transfers. Unfortunately, they have not yet given us permission to do egg retrievals in Windsor, but we are going to hopefully apply some further pressure to them at the college and see if they will respond, sort of positively. And in the meantime, we're doing them at Create. I was just there this morning. That's why I had to drive back. Great center, great people. And we've had nothing but good, reviews so far. So we're really pleased to be working with them as well. Dr. Liebrack and his team and the nurses there are phenomenal. I don't know if any of them are watching, but I've grown to really enjoy my time with them as well. So great center to be working at right now. Okay, I think we're just going to give a few more seconds for the remainder of the team to jump on. I do know that it's a holiday long weekend here in Ontario, so many people will probably still be relaxing and probably not thinking of their fertility at this moment, although I suspect many of you will be later tonight. So hopefully those of you who are watching can get more of your questions answered, and if we finish early, that's okay too, I don't mind. So this week's study is an interesting study. I'll sort of get right into it. The article is about pre-treatment before you went into your IVF cycle. So this wasn't for frozen embryo transfers. It was actually the full IVF cycle for patients that had endometriosis. So the basic idea is patients that have endometriosis, we know, don't do as well as other patients when they're going through their IVF cycle. So the whole idea is that we want to kind of maximize their ability to succeed. We want to optimize everything. We want to keep their immune system relatively quiescent and not have it overactive so that it's attacking the embryo or the embryo implantation process. And so in order to do that, you've got to approach it from the standpoint of using whatever medications or treatments you can to optimize things. So there have been studies done before which reviewed looking at the use of Lupron before embryo transfer, looking at Lupron plus letrozole, which is something I've talked about many times, before embryo transfer, and people have tried different things. They actually show a benefit. So there's one study that shows that if you use Lupron and letrozole before your embryo transfer, you'll actually do better. There's another study that shows Lupron alone will do better as well. And there have been several more studies up and coming that have all shown essentially the same thing. For patients with endo, if you pre-treat them before your embryo transfer, If you get enough suppression, they'll do better. So 3 to 6 months of down regulation with something that's going to reduce your estrogen levels to keep the endo quiet, and you're going to have a much better outcome at the end of the day. And those numbers are really quite significant. We're talking about like 20% differences in one case. I think it was 27% in another. So very substantial differences in live birth and clinical pregnancy. So Dianogest, which is the topic of this article, is also known as Bizan. And essentially, it's a type of progesterone called a progestin, so a cousin of the original progesterone hormone, that was designed specifically for women with endometriosis. So when women come to see me, not for fertility, but just for pain, we will frequently put them on Dianogest for treatment of their endometriosis. So that's a great option. It works really well. And those patients can get really good pain relief and suppression of their endo. So the nice thing about that is that treatment has way fewer side effects than getting Lupron and Letrozole. When you get Lupron and Letrozole, you're turning off your estrogen. So essentially what we've done to you, God help us, is put you on, or into menopause. And it's really like hardcore menopause, except you get it within a week of starting the medication. So hot flashes, night sweats, mood swings, vaginal dryness, decreased sex drive, sleep disturbance. All of those come kind of all in a rush. None of them are pleasant. And obviously, it's not optimal for the patients because now, on top of the fact that they're going through a stressful time with their infertility, they're also going through a stressful time because of their emotional state, their sleeping, their overall mental status, their well-being, oftentimes their relationship, because it can really affect things. So Dianogest is nice because it has almost none of those symptoms. You'll get some spotting. About 10% of women get headaches. Realistically, the rest of the symptoms are very minimal to none. So it's a very nice option for helping patients without having to worry about the impact it's going to have on putting them into menopause, because it doesn't put you into menopause. Now, there are some women that get some hot flashes on it, but I've never actually heard that as a complaint. It was just something that was in their original research studies when they actually compared it head-to-head to Lupron. So these guys went and looked at a prospective cohort study, which is when they start with a group of patients and they start following them through their journey and collecting data as the patients go through. So it's the next step down from a randomized controlled trial. But what they did was retrospectively analyze the data that came out of that study. So they hadn't originally asked this question. They went back and asked the question from data that was collected prospectively. So it's sort of a retrospective prospective study. So not as strong as a prospective cohort, certainly not as strong as a randomized controlled trial, but better than just a retrospective case control study. So essentially what they did was they looked at 151 patients and they divided it into 88 that got no treatment and 63 that got treatment. The patients were all patients with endo that they had diagnosed previously, mostly by ultrasound, and many of them actually had endometriomas, which are the cysts of endometriosis in your ovary. And that's important because I'm going to review how it impacted those patients once we go through the data. So essentially, they went back and looked and said, well, what were the differences between the populations? What were the differences in the outcomes? And were there subgroups that did better or worse, or had it better or worse, or whatever between the two groups to see, is there actually a difference if you're pretreated? Now, the interesting thing with this study is this was not pretreatment before your embryo transfer. This was actually pretreatment before your IVF. So I know everybody who comes to see us is in a huge rush. I've heard it all weekend long as I've been chatting with some of you to help you through your cycles. And everybody says, I don't want to wait. I don't want to wait. I want to go right away. I don't want to take another month off. I get it. I totally understand the pressure. We've reviewed before that waiting, even for those of you with low AMH or diminished ovarian reserve, up to 6 months actually doesn't make a difference. You have that time and the luxury. And the endo patients can, in some cases, be the same, especially if you're getting treatment to suppress your endo. But the overall result is they treated some of these patients, the 63, with 3 months of the Dianogest or the Vizan prior to actually going through their IVF cycle versus the 88 where they just rolled them into their cycle. So it does represent a delay in your treatment. You have to be willing to accept that if you're going through with this treatment. So I'm going to screen share. It is not the prettiest data to show you guys. And the reason that I say that is that it's in the pre-publication format. So forgive me for sharing data with you that doesn't look quite as great as we'd like it to. It's not really a pretty visual, but there it is. Okay, so for those of you that are looking on Instagram, I'm just going to read the numbers because it'll drive you guys crazy for me to try and show you all of this. So a couple of things that are important about this study population, which differs on average from our study populations, okay? The average age was 36, no difference between the two groups. That's probably roughly about our average, maybe a little bit higher for us. The average body mass index was between 20.7 to 21.0. So these are generally very thin patients, very, very thin. Now the study is out of Italy, so I don't know if this is just reflecting what the average Italian population is like. I can tell you if I ate pasta all the time, I would not be skinny. I have no idea how they're maintaining a BMI of 21, but the BMI for these women was very, very low. So that's important to consider, and that's a really critical element of this as well, because most of our patients are heavier. Heavier means that you're producing more estrogen. More estrogen means your endo will be worse. So can I extrapolate this study to our patients? I don't know, but you got to remember that when you're going through this data. Not all data applies to all patients. About 12 to 14% of the patients were smokers. Those of you that know me know that I won't even let you begin if you're smoking. About 54.5% in the non-treated group had endometriomas, the cysts of endometriosis, 60.3% in the group that did get treatment. And there was a little bit of a difference between the group that had no treatment versus treatment for the size of the endometriomas. They were larger in the group that did not get treatment compared to the group that did. So it's possible there was a slight difference between the two groups based on how significant their endometriosis was, because there was a little bit of a difference, 1.3 centimeters in the size of the endometriomas. It just barely made statistical significance, but it did make statistical significance. There are no other differences, the number of nodules that they had, the number of previously failed embryo transfers, previous pregnancies, or even previous treatment for endo. All of that stuff was the same. Okay, so that's all in this table here. And if you move down to the next table, for those of you watching on YouTube, they did a total statistical analysis on all the different things like AMH, FSH, their antral follicle counts, how much dose they used, how many embryos they produced, all of this stuff. There was no difference between the two groups at all. So in that sense, they're pretty fair for comparison. You can say these are apples to apples, not really apples to oranges. There was no differences in number of blastocysts, number of embryos transferred, the number of high quality embryos or the quality of the embryos. Everything was essentially the same. The only thing that they showed was that the implantation rate was higher with their fresh embryo transfer in the group that had the Dianogest. How much higher? Hugely higher, almost double, 32.3% versus 17.4%. So a big, big difference. Now, again, it just barely made the statistical significance, but it did make statistical significance. So they had a higher rate of implantation. Interestingly, that did not translate into a higher rate of clinical pregnancy or live birth past 24 weeks, which is the definition that they used. And the rest of the things that they looked at for subsequent embryo transfers was also not significantly different. So it looks like there is some impact overall between the two groups with a higher implantation rate, but it didn't translate into a statistically significant difference in live birth outcomes, which again, as I've always said, is sort of the holy grail. that was the initial part at the 24 weeks. But then when they went and looked at the cumulative rates, so this was per embryo transfer, when you start looking at cumulative rates, which is down here, so this is taking all the different embryos from each cycle and then seeing how they succeeded over time overall. So let's say your overall rate from 3 embryo transfers or 4 embryo transfers. The overall rate was statistically significantly higher for the group that had the Dynagest versus the group that did not. So how much higher? So the cumulative implantation rate, 39.7% for the treatment group, 23.9% for the non-treated. The clinical pregnancy rate, so that's seeing the baby's heartbeat going, 33.3% versus 18.2%, so close to double. And the live birth rate was actually double, 28.6 versus 14.8, so almost met doubling there. So they did see a cumulative doubling of the success rate in live birth when you're adding up all of the embryo transfers. So this is take 3 months of this Vizan first, go through the treatment, then do your IVF cycle. Then no matter how many embryo transfers came after, there's some lingering impact of that Dynagest treatment for 3 months that is translating into a doubling of your live birth rate. Now, you got to understand, in the world of IVF, doubling success rates is huge, in particular when your success rate is lower because of the fact that you're dealing with endo. Now, the success rate here is nothing for us to jump up and down about. They're only getting a 28.6% success rate. So that's definitely not optimal. We like to do much better. But nevertheless, they were doing even worse when they're not getting the treatment. It was down to 14.8%. So this is new data, has not yet been released. As I said, this is brand new. I picked it up today. And so this is really, really interesting for all of us because this is giving us a really interesting look into what could possibly or potentially be coming about down the line and down the pipeline in terms of not just treating people after they've done their IVF, but treating people before they've done their IVF to try and maximize the success rates. It may well be that if we pre-treat you, do your IVF cycle, which unfortunately does increase your endometriosis, and then re-treat you before a frozen embryo transfer, that you would do even better. And there is data showing that if you pre-treat before the frozen embryo transfers, you definitely do better. So they did do one more thing that was kind of cool. They looked at the group that had endometriomas that were large, bigger than 4 centimeters. Okay, so that's a fair size endometrioma. And keep in mind, none of these people are getting surgery. The numbers are low. They are only 18 in one group and 16 in the other, but they still went through and looked at the data. So they picked up some really, really interesting points here, and I want to highlight those for you. The antral follicle count was higher in the group that had the Dynagest pretreatment. So that means that when you showed up for your first ultrasound, you actually had more eggs at baseline, 5.9 in the untreated group versus 8.3 in the treated group. So that's actually quite significant. The next thing that they noticed, the number of mature eggs also higher. It was 6.1 in the treatment group versus 4.3 in the untreated group. So almost 2 extra mature eggs. Again, that's really important, kind of reflective of what they're seeing with the antral follicle count. You're seeing 2 more eggs, and then you're getting 2 more mature eggs at the end. The number of normally fertilized embryos also higher by 1.3, 3.5 in the treatment group, only 2.2 in the untreated group. There was no difference in the number of Class A embryos or the number of people that had at least one Class A embryo. There was, however, a difference in the number of blastocysts, almost double, 2.5 in the treated group, 1.3 in the untreated group. And the number of embryos that was transferred was actually a little bit higher ultimately, 1.6 in the treated group, only 1 in the untreated group. But the neat thing here, or not neat, but unfortunate thing actually here is, again, they did not show a difference in the outcomes as far as live birth or, clinical pregnancy or anything like that. And I'm scrolling through it here, but again, for my Instagram friends, I can't show you this, guys, because we can't run two platforms at the same time. But nevertheless, the reality is that the data from this group shows that there is no difference even when they looked at it cumulatively. But again, we're dealing with very small numbers, and I highly suspect that if they had more robust numbers, they actually would see a difference. So where does all this leave us? Well, the reality appears to be that if you pre-treat before the IVF cycle for a couple of months, as frustrating as that can be for you guys, and believe me, I get it, I know how frustrating it is, you may actually end up doing better cumulatively in the live birth outcomes. So it's something that we need to consider from now on, moving on. I always tell my patients rushing into IVF is never a good idea. Sometimes taking a couple of months to make sure everything is perfect can actually make the difference between an unsuccessful cycle and a successful cycle. And that looks like it not only has an impact right away, but it may actually have a lingering impact that can go through into subsequent embryo transfers and ultimately get you to where you want to go, even if it doesn't succeed on the first try. So is it a fact or a fiction that Dynagest pre-treatment for endo patients can improve success? It is a fact. It does appear to improve your success rates with your cumulative live birth rate, and that is the holy grail. That's the thing we're looking for. So thank you for joining for that part of the show. I hope you found that interesting. I think it's going to be an exciting paper and stir up some interesting controversies. And join us always on our YouTube channel, where you can find all of our videos every month and every week. And like, comment, and subscribe. We want to drive people there because we have all of our programs there, the short videos, the longer videos, everything we've done. We're going to have a really cool Which Pregnancy Test kit to buy review video coming out soon too. I'm actually having to test people early at like day 8 and 9 to see if they're pregnant, and then collect their urine so we can see how early the urine kits will detect. So we'll have that up and running for you hopefully pretty soon too. So I'll start taking questions, and I'm up for whatever you got. Do you have any there?
No.
Okay.
They don't want you today.
They don't want you today?
They're all alive.
All right, let me go back to our main program there. Okay, so I've got a couple of Facebook questions. Hi, Ash. Good evening. Hi, I have a question about embryo glue. Let me put that one up so they can see it. How much does it cost, and the success rate, fresh and frozen? I think fresh and frozen, thanks, it says. So embryo glue is something that is designed to supposedly improve the chances of implantation. I think the cost is usually like a couple $100. We don't do it because every single trial that has been done properly to test the validity of embryo glue has demonstrated no benefit whatsoever. So I'm not a believer in embryo glue. You'll probably get a bigger result or a bigger success out of just doing an endometrial biopsy, and we've reviewed that on the show, although admittedly that also is hugely controversial. HCG therapy, which really should not cost you more than $100, that has been proven to be beneficial. We reviewed that on the show. I think that was before winter, like late fall or something like that. Right. That's on the YouTube channel as well. A quick HCG injection 15 minutes before your embryo transfer does the trick. It's not expensive, and you'll get the same outcome and yield as you will with embryo glue. So don't bother with embryo glue. It is not going to help you. Congrats to the family to be, of course, to you and your office family. Yeah, yes, thank you. At the start of the show, we were talking about our first ever embryo transfer. They're pregnant with twins, so we are super excited for that. Also, if my retrieval is on the 14th, when would the fresh transfer be? And would it be in Toronto or at the Sarnia or Windsor office? So if it's a fresh transfer, it has to be in Toronto. And we don't do a lot of fresh transfers unless you're doing a natural cycle, and sometimes mini. But otherwise, we tend not to do fresh transfers because the frozen embryo transfers have been proven to be a higher success rate. So that's important for you to know, Ash. Would the drug you were discussing during this fact or fiction have any benefit for diminished ovarian reserve? Well, that's a great question. Not that I'm aware of, although they are saying for the endo patients, which do typically have reduced AMH levels. And there are studies that show that there are a higher number of eggs. What an interesting thought that is. I wonder if we could run a study to see if pre-treatment actually increases the number of eggs they produce. Great question. There is no data out there. There are probably more sure ways to increase the number of eggs. For example, testosterone therapy has been proven to increase the number of eggs. DHEA has good data supporting its ability to increase the number of eggs. I don't know that this would be prudent, but it's an interesting question. There's no data for it. I can't answer that for you for sure. Okay, I got to go to Instagram. And for sure, if you guys have any questions, don't hesitate to ask. Oh my God, there's like a million people here. Okay, so how do you get pregnant with twins through IVF? You put in more than one embryo, which we are reluctant to do for several reasons. So if I put in two embryos, you do have a higher chance of ending up with twins. If they're two good quality, genetically normal embryos, it's around a 70% chance of having twins. And that's from a study from CCRM in Colorado. So the problem with it is that if you do that and you end up with twins, number one, it's an automatically higher risk pregnancy for you. High blood pressure, diabetes, preterm delivery, bleeding, need for hospitalization, preterm rupture of membranes, abnormal presentation necessitating cesarean section, more complications at delivery, more problems with the placenta. Like I could sit here for the rest of the show and just rhyme off literally the complications of twins. So there's a problem for the babies. There's problems for you. That's the preeclampsia, the high blood pressure, the diabetes. So there can be problems for the moms, including blood clots, which can be deadly to you. And then there's a problem with you and your partner because the divorce rate amongst the parents of twins is 80%, 80. The normal divorce rate is unfortunately 65, but it jumps up to an even higher rate when you get to twins. So it is possible to do it. And in certain circumstances, it's justified. But generally speaking, it is something we do not encourage and we avoid. Now, if you come in here and you're 45 and you've only got two embryos and they were batched together, I probably would say it's not unreasonable. But if you're 30 or 32, we don't encourage it because it's much safer for you to do it one at a time than it is batched together all at the same time. Okay, whoops. And if anybody on Facebook or any of the other ones has questions, don't hesitate. Hi, people are saying hi to me. Hello back. What are the chances of miscarriage with a PGTA normal embryo? Oh, that's a fantastic question. Okay, so the question is, what are the chances of having a miscarriage if the embryo has been tested? So the research shows that it's probably somewhere around 5 to 10%, but it does very much depend on you. If you've had previous recurrent pregnancy losses, if you have endo and overactive immune system, fibroids, polyps, if your body mass index is too high, your vitamin D isn't high. I mean, there's a million things that go into it, but perfect patient, two perfect embryos, it should be only around 5%, less than 10 for sure. Whereas normally in an IVF study, large studies, you are looking at around 15 to 20%. So there's definitely a reduction when you do the PGTA. Interestingly, in my experience, we have had some patients who were younger and did the PGTA, and they actually ended up with miscarriages with the embryos that were genetically normal. I do believe, and I can't back this with science, but I do believe in my heart of hearts that patients that undergo PGTA and are less than 38 actually get some degree of damage to the embryos that they are not supposed to sustain, and that damage can actually increase the chances of miscarriages. Otherwise, it's inexplicable why a perfectly normal, healthy embryo would go in, implant, stick, start to grow, and then miscarry somewhere down the line. It really doesn't make sense. And we've even seen it where you'll see a heartbeat and then you see the pregnancy loss. So that kind of thing just doesn't make sense, and it needs to be addressed. So we don't encourage it for younger women. Your recording stopped. But for older women, we do. And I'm not saying old women, older. Can a woman having hypothyroidism irregular cycles and fibroids still be diagnosed with unexplained infertility? No, definitely not. So off the top, your irregular cycles are the cause of your infertility. Fibroids, depending on where they are a problem. Hypothyroidism is not necessarily a cause of infertility, but it's super easy to treat, so it shouldn't be a problem for you. That should be easy to manage. Is there a benefit to do IUI before IVF to see how you react to the medication? Yeah, for sure. We do trial runs with the meds, especially if you have diminished ovarian reserve. But you can set it up two ways. So you could go into your IVF cycle, try and make as many eggs as possible. And if you're not doing well, we just cancel your IVF cycle and we flip you to an IUI. Or you could say, I just want to try the IUI. And then if I'm doing well, we'll either finish the IUI or we'll, stop. The problem that we do run into sometimes is some people want to say, can we start with the idea of an IUI, but push my ovaries harder? And then if it looks like I'm making too many eggs, we'll flip into IVF. The problem is I'm never going to give you the same amount of drugs I would have if we were going straight into IVF, where we want as many eggs as possible. So you may end up with fewer eggs than you could have. So that's not a great plan, but we certainly have no hesitation to canceling your IVF cycle and then letting you flip into an IUI cycle as long as you do it quickly enough. So I'll give you a great example. I just did that for somebody 13 days ago, well, a little more than 13 days ago, so probably about 18 days ago now. And she was in an IVF cycle. She actually had quite robust ovaries, and she just wasn't responding the way she was supposed to. So we said, you know what, you're not doing as well as you should be. She was actually making enough eggs to go ahead with the IVF cycle. There were probably 5 or 6 available, but I knew she could make like 15 or 20. So I said, you know what, I'm not going to do an IVF cycle with just 5 when I can get 15. Huge waste of money for her. Would not be ethical for me to do that, in my opinion. So I said, look, we're going to cancel your IVF cycle, but we do have enough eggs that if we tone it down, we don't need to get all 5 or 6. We might just get a few. We can go ahead and do your IUI instead. You won't have lost the cycle. And, if you get pregnant, hallelujah. And if you don't get pregnant, then we just roll into your next IVF cycle and adjust what we were doing to hopefully get a better response. She got pregnant from the IUI, and I just tested her yesterday or the day before yesterday, and she came out positive, and we're super happy and excited for her now. And she's avoided all the expense of the IVF cycle. So I'm thrilled for her. She saved herself thousands of dollars, and it all worked out great, and all we did was the IUI. So yeah, I totally believe in doing it. You just got to structure it the right way so that we're doing the right thing for you. Okay. Somebody wanted to be in our live video on Instagram. I can't put you in our live video on Instagram because of the fact that nobody else would be able to see it, guys. Sorry. For a 44-year-old with no previous issue and 1 natural pregnancy, how many eggs do I need to get the golden egg? Ooh. Okay, so at 44, probably about 85 to 90% of your eggs are genetically abnormal. So, or embryos at least, will end up being genetically abnormal. So let's be optimistic and say 80%. It's probably higher than that, but let's be optimistic. We'll say 80. So at a minimum, you're going to, well, it's probably higher than 80. I'm being unrealistic. 90%. So if you say 90%, then you need 10 embryos in order to get 1 that's genetically normal. So that's 10 blastocyst embryos. And you actually need 2 because only about 50 to 60% of genetically normal embryos will actually implant and go on to become a live birth. So you actually need like 20 blastocysts. In order for you to get 20 blastocysts, you would probably need 50 eggs. The average 44-year-old is probably going to make 3. Maybe 4. And that's why the math for this stuff is so important, because most centers don't tell you that you need an overwhelming number of eggs in order to find that 1 golden one. The problem with it is I'm just presenting you with numbers. What I'm not telling you is you could find that golden egg in the first try. So that's a possibility. It's not that it's sequential and you've got to go through 50 eggs to get to the one normal one. You might actually have that on the very first go. So, it's very, very possible, but you would need a lot at 44 to end up yielding 20 blastocyst embryos. The strongest 45-year-old I've ever seen made 22 eggs that were mature. We ended up with 14 blastocysts for her from 22 eggs, and we sent them all off, and we got one genetically normal one back. I put it in her, and she was one of those ones where it was genetically normal. She made it to 11 weeks, and she had a miscarriage. So there are other factors that we need to consider when we're dealing with patients that are older that can hinder or hamper the whole process. And it does not always run smoothly, even though we've done everything possible to make sure that we've got it as honed in and dialed in as we possibly can for your success. Okay, what's next? What is your opinion on L-arginine and vitamin E before transfer? Vitamin E thickens your lining, so I think vitamin E is a good choice. There's nothing wrong with that. We use it frequently for our patients that are not thickening their lining enough. So does vitamin D, aspirin, other things. L-arginine, I'm not aware of data on L-arginine for women before transfer, but if you're taking a decent prenatal or a really good prenatal, it probably has some. I would have to look up the impact of that in women before transfer. It is very useful for the guys for their sperm, but I'm not aware of any data for that before an embryo transfer. Jen Strong from our naturopathy division here may have an answer on that. Jen, if you want to chime in and answer if you're watching, we would love to hear from you. So send us a message and I'll throw it up there for everyone to see. Would you consider using Vizan now? I'm waiting to hear from your office on when to start IVF. I have an endometrioma and a history of an endometrioma surgically removed. I would. I mean, either Vizan or Lupron. We've used the Lupron before. Up until this article, my philosophy was the following, and I'll explain why. Do your IVF cycle, freeze all your embryos, go on Lupron and letrozole for 3 months, and then come and do your frozen embryo transfer. So the question is, why am I saying that? Well, because we know during your IVF stimulation phase, even if you've been on something ahead of time, that we're actually worsening your endo because we're driving up your estrogen levels, making as many eggs as possible. So when we make more eggs, we know that we are making more estrogen. When we are making more estrogen, we are stimulating your endometriosis. There is no question about that. So to me, it made sense to say, look, we're going to make the endo as bad as possible unintentionally, but at the same time, knowingly. So why don't we just let that happen, then get your embryos out, protect your embryos, keep them frozen, shut down everything so your body goes back down to hopefully as close to a normal state as possible. There's good data that supports using the letrozole and the Lupron for 3 months, then going ahead and doing an embryo transfer. With this study, this is actually suggesting that maybe we should be using that Dianogest ahead of time and then also doing that second part based on the other studies. There aren't any that have combined both ends, but I'm sure someone's going to do that very soon. And undoubtedly, it's going to give you a better result. The downside, you're talking 6 months of delay. Now, is that a problem? No. In fact, if anything, according to all the data, it's actually going to improve your success rates. But mentally, for a lot of patients, it's a problem. They can't handle that kind of weight. So you got to factor in your stress level during that 6 months versus the benefits of it. And that's why we have such a robust program for stress. So I say this over and over again, but psychologist, social worker, our naturopath who's amazing, Jen Strong. We've got an online program called Organic Conceptions that we give you guys for free. Anybody that wants it, just let us know. We'll put you on board. So we do a lot. We have a nutritionist. We have an addiction specialist, all sorts of things that we can do to maximize your success. We're going to try and do for you guys to make it as good as possible. So don't hesitate. If we can help reduce the stress, get you the best outcome, That's what we're all aiming for. How many days of bed rest do you recommend after an FET? Maximum 1. So the data actually shows that there is no benefit to resting at any point in time. But if you feel less stressed resting, go ahead and rest. If you feel less stressed going back to work, there's a study out of California that actually says go right back to work. You don't need to wait. There's no reason to go home and rest. You actually get the exact same outcomes. In fact, it was better in the group that went back to work. The hypothesis behind this is the patients that go back to work are less stressed because their mind is occupied and they're busy. And when your mind is busy, then you have less time to dwell on, oh my God, I had this symptom or that symptom. I should go check on Google. My shot went in funny. My progesterone wasn't quite right. What if this happens? What if that happens? Why didn't I do this? Why didn't I do that? So you can actually increase your success rates by doing whatever is going to stress you the least. So if you're less stressed at work, go to work. If you're less stressed at home, stay at home. That's fine. Okay. Success rate of PGS tested normal 5BB embryo. Oh, guys, you're asking me impossible questions. It depends on the scoring system, and it depends on your age, of course, as well. But a PGS tested embryo, regardless of its grade, probably has about a 50 to 60% chance of implanting. In the best programs, a little bit higher, 63, 65, but you should have somewhere around half to a 2/3 chance of the embryo implanting. Until what week of pregnancy do you recommend we take progesterone suppositories and PIO? Okay, I'm not a fan of changing that. I'm in the extreme minority here, but I actually make my patients take it for the full 12 weeks. Then we wean you off of the PIO because it's horrible. But we keep you on the vaginal all the way to 36 because the fertility patients are higher risk. And when you're higher risk, we want to avoid things like preterm labor. And you are at a higher risk of preterm labor when you're a fertility patient. So taking progesterone reduces that by 46%. So it makes sense to stay on the progesterone. Do people have more allergies with sesame oil or ethyl oleate PIO? In my experience, people tend to react more to the ethyl oleate. They get those like great big pink welts. So sometimes they do better on the sesame, but everybody's different. And in some cases, we actually pre-test them to see, who's reacting less or more. So those patients need to take some trial shots of progesterone a month or two in advance just to see which gives them less irritation. If you're getting those big pink welts, your immune system's getting seriously overactivated. Those patients don't do well in my experience. They actually don't implant, they don't get pregnant. I think because the embryo is suffering from reaction to everything. What are your thoughts on assisted hatching? What type of patients would you recommend it to? So the previous embryologist I worked with believed everybody should be assisted hatched. My current embryologist does it for our frozen embryos. As for everybody else, women with a thick zona, so that's the shell or the wall around the embryo, they need it. There's some belief that women that are older in their reproductive years, that they also need it. And then recurrent failures in the past, that's another indication to do it as well. So there are several groups of people where they've shown some benefit to assisted hatching, but not everybody. Jen Strong just messaged me on my message, but I think if I get out of this, it's going to cancel it. Jen, you're going to have to respond on Instagram or Facebook because I can't read it here. So I love you, Jen, but I can't read your thing or else I'm going to cancel everybody watching on Instagram. What if my husband is only 29 and he had no sperm and is testing for analysis? Oh, wow. I'm so sorry. So if your husband has no sperm, you need to go through the steps of figuring out what was wrong with your husband. So there's one of 2 or 3 categories. He's either not producing sperm, which is either because of a lack of signal to make sperm, which is fixable, or a lack of function of the testicles, which is usually not fixable, or he's not producing sperm because it's trapped, it's blocked. That's an easy solution. We can extract the sperm. So if he's got testicular failure, that's really tough to fix. If he's got normal testicular function, but they're not coming out, then it may be because either he's not sending enough signal from his brain, which you can fix by giving guys Clomid or HCG therapy, or you can just extract it if it's not able to get out of the testicle or the epididymis during ejaculation. So there are some that are fixable, there are some that are not. You need to have your fertility specialist determine what the cause is, and then they can answer that for you. And I'm sorry you're going through that. I took L-arginine, vitamin E, and D. I believe it helped thicken my lining, right? So that's from one of my favorite people ever. Yeah, that stuff works. It does thicken the lining. There's good data for vitamin E and D. L-arginine, again, I haven't seen data on improvement, but if people are saying it works, I would have no doubt. It's certainly not harmful, so you can take L-arginine. It's not going to do anything bad. When do you recommend ERA test before or after stims? Oh boy, here's my ERA story. So I was a big adopter of ERA when it first came out. Hook, line, and sinker, I went for it. Then we started carefully monitoring progesterone levels. It actually makes no difference when you monitor progesterone levels. And we noticed that after doing the monitoring closely and saw that we're really just not seeing a difference in the outcomes. Less than 5% of patients are asynchronous in their endometrium if you're carefully administering and monitoring progesterone levels. On top of that, there's a lot of other things that are important, like the compaction of the endometrium, which they don't even tell you to look for when you're doing your ERA test, and the contractions of the endometrium when you're looking on ultrasound. So there's a bunch of factors that have become important for us to observe and be cognizant of that have nothing to do with the ERA test. Now, I will tell you that in Reproductive Biomedicine Online, one of the journals, actually the same one that I pulled the article for tonight's show from, there is going to be a study published showing very soon that after 5 years of research, the ERA test was beneficial. However, and I'm going to spend some time on that one in a future Fact or Fiction, 50% of the patients that were assigned to one of the groups dropped out of the group because they didn't follow through with it. Why, I don't know yet, because I've not seen the full article, but I'm going to study that for you guys and bring it back to you. So as of right now, I remain a very convinced non-believer in ERA because I've tried it and it does not work. On top of that, if you just go back to last week where we reviewed the difference between day 5 and day 6 progesterone dosaging and seeing if 5 days versus 6 days of progesterone makes a difference, in the people with 5-day embryos, it actually makes no difference if you go a full day. And there are multiple studies that have shown that. So you can actually go a full extra day of progesterone, which the ERA people are saying, oh no, it's like 6 hours. There's data out there showing you can go a full 24 and it doesn't make a difference. And for the people that have day 6 embryos, they're saying you should actually go the full 6 days of progesterone so that you're transferring on the morning of the 7th day because they actually have less miscarriages and a higher success rate. ERA doesn't even talk about the day of the embryo. So I think there's a lot more that needs to be worked out before we start adopting the ERA test. As of right now, it's not real at all. And I can tell you, having actually spoken directly via email with the head science guy for iGenomics, when I asked him for the data, he sent me a non-statistical, not even a trend, and said, look, there's a difference in the numbers, so it's different. And I said, it's not statistically different, and I couldn't even believe that he was trying to pass that off as being real. It wasn't even close. So there are no studies published yet that have demonstrated a significant difference, and I highly suspect that this one that is about to be published is very questionable. I'm sure someone will sit down, reanalyze the data and say that when you do it according to what the actual patients ended up doing, that there was no difference in success rate. So don't waste your money on that yet. Okay. I think that's starting supplements. Recommended CQ10, yes. Omega-3, yes. Folic acid, yes. Magnesium, sure. Vitamin D, vitamin D, vitamin D, vitamin D. Vitamin E is probably helpful. You can take them all at once. Those are the basics for us. Iron will help as well, B12. So make sure you're getting all of those things. Vitamin D is hugely important. You should have your vitamin D levels measured first before you even do your cycle. How about zinc? Zinc is good too. Zinc is a great antioxidant. And the more oxidative damage that's in your body from whatever, the better or the more helpful those antioxidants are. So we strongly advocate for as many antioxidants as you can cram in there. They're all going to help you. What additional procedures are most beneficial, such as PRP, endoscratch? Okay, so I'm assuming this is for embryo transfer. So PRP can thicken your lining. It has never been demonstrated to actually result in a statistically significant increase in live birth. So keep that in mind for PRP. And I don't recommend it in general. Endoscratch is still controversial. So last year we did an article during Factor Fiction on whether the biopsy was useful or not. And literally a week later, they published a different study saying the exact opposite of what we had presented. So it's super controversial. For every study that says that it helps, there's another one that says that it doesn't, and people keep flip-flopping back and forth. I still believe in it. I think it overall makes sense, but not everybody does. Making sure that your vitamin levels are high is important. Making sure that your diet is healthy is important. Get rid of as many plastics, toxins, chemical exposures, things like that. That's really important. Make sure you are healthy yourself. Your body mass index needs to be reasonable. And by reasonable, I mean ideally under 30. And if you're not under 30, you will have a harder time. So drive it down towards 30 or less than 30. You need to eat healthy, so low sugar, low carbs. You want a Mediterranean diet. That has also been proven. We have a Factor Fiction on that as well. So you want the Mediterranean diet. It will improve your success rates. And then you want to do the adjunct things that we know work. So progesterone monitoring. You want to make sure that your progesterone levels are adequate. You want to make sure that your endometrium shrinks after you've started your progesterone. You want to make sure that the thickness is adequate, and then you want a good embryo transfer. HCG before the transfer, and HCG wash, as they call it, also has been proven to be successful. So those are kind of the overall overarching things that we know are beneficial. Letrozole helps with frozen embryo transfer cycles. And then there's that whole other world of the vaginal microbiome. We've also reviewed that in a previous Factor Fiction. The bacterial content of your uterus and your vagina are enormously important to your success rate. So we actually treat our patients with antibiotics, and then we put them on a probiotic to restore good bacteria back to the uterus and the vagina in an effort to maximize the chances that we're getting the best milieu or environment for our embryos that we can. Okay, where are we at? 53? Mm-hmm. Yeah, a few more questions. Sorry, we're just getting a knock at my door. We'll take care of that. Okay, so I was given a Lupron depot injection, but I don't have endo. How would it benefit me? There are actually patients who will do better with Lupron even if they don't have endo. Those are the patients who have had recurrent implantation failures. So there is a group of patients that actually have improved outcomes from their frozen embryo transfers if they do a Lupron shot for 3 months. And there's actually data showing that that's true with Lupron and letrozole together as well. So the Lupron before can actually help if you've had previous failures. Is it helpful before just the general IVF? Not to the best of my knowledge, but it's also not harmful either. So, there may be some benefits. Can you take probiotics even after an IUI? Yes, for sure you can take probiotics after an IUI. Is there something to do or to take for your progesterone and HCG goes up? Liz from YouTube, I have no idea what you mean by that, dear. Is there something to do or to take for your progesterone and HCG to make it go up? You certainly can't make your HCG go up unless you're pregnant. Can you naturally do something to make more progesterone? No, you can't. Yams have some natural progestins in them, but realistically, you can't take something that's going to increase your progesterone level because your progesterone level is determined by the egg that you've released. So there's nothing natural that's going to alter that, if that's what you're asking me. 5 failed IUIs, I'm sorry, sweetie, and 1 failed single FET with our remaining embryos frozen in pairs, not by choice, I get it. A little nervous since strongly advised single transfers. I'm 32 with no health issues. Yeah, I mean, I wouldn't be nervous. We're certainly happy to go ahead and transfer the 2, and if they're frozen in pairs, that's okay. To everybody who has embryos frozen in pairs, I know why that was being done. And the theory was, in many cases, that 1 out of 2 would be abnormal, so it made sense to batch them together and put 2 in at a time. But I get it. We don't want you to have 2 normal embryos and then end up with a problem pregnancy. I will tell you that we are really careful with our twins. If you're staying on progesterone the whole time and baby aspirin, it avoids the majority of the complications. I cannot remember the last time one of my twins actually had a problem. So we've done very well for many, many, many years. You will, of course, run into some trouble. But if you're vigilant as an OB, as an obstetrician, taking care of the pregnancy, you can avoid most of the problems that way. So don't worry. We'll take good care of you. If someone had an endometrial ablation, but lining is still measuring 6.5, would you transfer an embryo? No. I've done it before. It was a disaster. She made it to 19, 20 weeks, and she delivered the child at that stage. The damage done from an endometrial ablation to the underlying vascular structure of the endometrium is way too significant to support a pregnancy. Almost for sure, you will end up with an abnormal placenta, and that can be harmful to you, including life-threatening. So I would not recommend doing an embryo transfer after you've had an endometrial ablation. You need a gestational carrier. Thank you. I appreciate all you do. I am so lost and confused about it now. I am sorry, Shani. Don't be lost and confused. We will do whatever we can to help you. What is lining compaction and how do doctors check for this? Okay, last question real quick. After you start your progesterone, your lining needs to shrink in response to the progesterone. So let's say right before your progesterone, you're at a 10 millimeter. It needs to be smaller than 10 3 days later. So we just bring you back and check on ultrasound. If the lining isn't shrinking, the success rates are way lower. So that was published in Fertility and Sterility. It was from the clinic in Toronto called Trio. Dan Naot, a friend of mine, was one of the main authors. Great guy, very smart guy. And so they came up with that. So we're going to sign off unless anybody has any questions. Last minute. Have a great night, guys. Thanks for joining us as always. We are really pleased to have you all on board. Love answering the questions, and we'll definitely have you all back. One last quick question. I doubt I can even read it in time. I have intestinal motility problems and then deep in FET territory. Can you take motility stimulating drugs without causing uterine contractions? Probably not, and they'll raise your prolactin levels, which will mess with your lining, so don't do that. Have a great night, guys. Take care, and I wish you all the best. Get your gut fixed before you do your embryo transfer. That will be important. See a naturopath. They can do wonders for you. Take care, guys. Have a good night.